Good afternoon. We're going to get going on our webinar. So welcome everyone to the webinar, Increasing PrEP Uptake, plus an overview of what's new in PrEP. This webinar is part of the California State Office of AIDS Prevention Webinar Series. My name is Linda DeSantis. I'm a program manager with the California Prevention Training Center in Oakland, and I'll be hosting today's webinar. This webinar is sponsored by the California State Office of AIDS Prevention Branch in collaboration with the Pacific AIDS Education and Training Center and the California Prevention Training Center. We also have the Curry International TB Training Center helping us produce the webinar with their technical assistance. All three training centers have a national and international focus, providing training and technical assistance to public health departments, CBOs, and private health care settings to increase capacity of the public health workforce in HIV, STD, and TB programs. We have collaborated for many years and find that our training audiences cross over, so it's good for us to be working together on this. Before we start with today's presentation, I want to cover a few housekeeping items. First of all, we're recording this session for future reference. So if you have dialed in, please make sure to continue to mute your phones. The link this recorded webinar will be sent out to all who have registered. It will also be available on the California PTC and the PAETC websites for review or for people who were not able to attend today. We'll be using the chat box to take questions. So please type in your questions as they come up. We will address questions at the end of the session. And any questions that we are not able to cover will be collected and will be sent out to everyone who has registered. For a little practice, we would like to ask anyone who is logged in and watching with a group of coworkers to type in the number of people that are with you in the room in your chat box. Great, we're seeing some people are watching it together. That gives us a better idea of the reach of the webinar. So thank you for doing that. So the same feature that you're logging in your number is how you'll ask us any questions that you may have regarding the content of the webinar. If you need assistance during the webinar, you can raise your hand by going to the icon above the slides. And we'll be checking in with you via private chat to see how we can help you as to not interrupt the presentation. If you are experiencing any delay in slides advancing or audio during the webinar, this is likely due to a slow network connection at your setting. Please be patient. Usually the audio is fine even if the slides do not advance in sync. There may be nothing we can do on our end, but you will get a recorded version post-webinar. This webinar series, which continues through February, will address current topics relevant to HIV, STD prevention programs. Today's webinar highlights the PrEP Navigator Manual developed by Project Inform to help you promote PrEP for your clients. We're also going to cover an overview of what is new in PrEP as outlined from the recent International AIDS Conference. Presenting today's webinar and presenting on increasing PrEP uptake, we have Alan McCord, who is currently Director of Education at Project Inform, where he has served in various capacities since 1998. His HIV work has spanned nearly 30 years in regional prevention and education programs in Ohio and New Jersey, and for 2 national organizations based in San Francisco. He currently oversees a portfolio of patient care, treatment, and prevention materials on HIV and hepatitis C with an emphasis on PrEP. We also have Rosalyn Plotzker presenting on what's new in PrEP. Roz is the Sexually Transmitted Disease Fellow for the California Prevention Training Center and the California Department of Public Health STD Control Branch. She received her medical degree from Downstate Medical Center and completed her preventive medicine residency at the Icahn School of Medicine at Mount Sinai Hospital, where she also earned her Master's of Public Health in Health Promotion and Disease Prevention. As a fellow, she provides clinical care at the San Francisco City Clinic. She also contributes to STD prevention education, programming, and research with both the CAPTC and the California Department of Public Health. I want to welcome both of you today, and Alan, we'll begin with you.
Thank you, Linda, and good afternoon, everyone. Before I start, I wanted to give a big thank you to the PAETC and the PTC for inviting me to present today, so thank you for doing that. What I'd like to do is to outline some of the content in the relatively newly published manual, Helping People Access PrEP. It's a collaboration between Project Inform and PleasePrepMe.org, as well as other community advocates and programs, not only in California, but around the country. So it truly does take a village. We wanted to create a manual with relevant information that can help local PrEP navigation staff more fully serve their clients. Essentially, baseline information in three main areas of PrEP services. First, the research that supports its use. Second, ongoing PrEP care. And then third, navigation best practices. The manual currently addresses 46 topics, so that's not quite something I can cover adequately in 30 minutes today, but as I highlight content from each of the three large sections, hopefully I'll provide some new information for you today, or at least pique your curiosity enough to read more of the manual later. I'll also say that I don't provide face-to-face contact with PrEP users myself, so if I miss the mark on what actually happens in your offices on a daily basis, please forgive me for that. And you can see at the URL on the slide where you can access the manual. We designed the manual to contain full pages of information that might be useful as handouts for your clients. So please, I encourage you to feel free to copy away and hand them out as needed. As I said, the manual is free to download at that URL, and you can sign up also on that page to get updates to the manual as we provide those over time. So let me get on to the first section, which is on PrEP research. You can see the topics listed there, and I'll give you a moment to read through them. I'm not going to go through each of these one by one, but in my humble opinion, I just wanted to highlight some of the points, the major points of interest, as I think might be interesting to you. In my experience, over the past couple of years, most PrEP users aren't asking about the nuts and bolts of data like this, at least for the current form of PrEP. But I am hoping that these pages provide navigators and you all the basis for why PrEP is effective and how to frame your conversations with PrEP users. In this first topic page that I wanted to highlight, sometimes people ask about just how PrEP actually works within the body. So this page can help you out with that, with simple graphics about how it works. So again, this is just a very quick way of being able to copy it and hand it out as needed as your clients ask about this. Next, I wanted to highlight that although the PrEP research field has a rather deep pipeline, as you can see in this graphic on the slide, we currently only have one approved PrEP intervention right now, and that's Truvada for PrEP, daily Truvada for PrEP. And that will likely be the case for another 2 years before any of these other interventions might make it to FDA approval. I said earlier that I don't hear questions about the current form of PrEP, at least at the clinical study level, but on my experience on Please Prep Me, we do hear things like, I heard there's a new shot that I can get, or maybe something like, I heard you don't have to take PrEP every day. So some of this information in this section could be useful to you and your clients. Closest to possible FDA approval would be the Descovy pill, which is an updated version of Truvada, and perhaps injected PrEP. But one thing I wanted to point out is that one strategy, which you might have heard about along the way, is non-daily or sex-based PrEP, which is what the French Hypergay trial studied. And that is taking pills just prior to and after sex rather than daily from week to week. I bring this up because although this dosing is being promoted in France and other areas in Europe, it's not FDA approved here in the U.S. We'll be including a new page on non-daily PrEP in the near future in the manual, so I can let you know when that happens. We've included in the manual one page on observations from clinical studies that may be useful to you. This page details general observations collectively from many PrEP studies. So for instance, for rectal exposures, blood drug levels that are equal to or higher than 4 doses per week showed a 90 to 99% reduction in transmissions. So this means missing a dose every now and then doesn't appear to be an issue for rectal exposures. So in this case, PrEP is more forgiving if somebody forgets a dose or misses a dose. For vaginal exposures, daily PrEP provides 90% reduction in transmissions for men and women. However, unlike rectal exposures, some infections were seen in cisgender women among those who took 4 to 5 weekly doses. So this data points out that there are differences between rectal and vaginal or frontal exposures, and it's important to convey this information that maybe for rectal exposures, missed doses is more forgiving, but for vaginal or frontal exposures, it's less forgiving, and it's more important to be on daily dosing. In other studies, real-world studies, such as the data that's coming out of Kaiser and Strutt, can provide more details on STI rates, best practices, and real-world use. Although no trans men were knowingly enrolled in studies, and few trans women were, expert opinion currently is that hormones do not interfere with PrEP efficacy, and most of that is due to the fact that we've been using Truvada for more than 12 years, and hormones are not interfering with the treatment aspect of using Truvada. So, although once current trans women's studies are completed, there are a few going on in the United States currently. New information on best practices in trans communities, at least for trans women, will become available. Another section I wanted to highlight in this first part of PrEP research is TASP, because I think treatment as prevention is also using HIV meds to prevent transmission, only in this case for people living with the virus. And I think TASP goes hand in hand with PrEP for many communities and individuals. One, personally, I don't think enough people know about TASP. And two, as navigators, you may come across mixed status couples who are trying to decide about using PrEP along with TASP. Some may choose not to, as we've seen a large body of accumulated data pointing to this phrase, undetectable equals untransmissible, which generally means it's highly unlikely, and some people say impossible, to transmit HIV when a positive person stays undetectable over time. So for some couples, TASP on its own may be sufficient to protect the negative partner. For others, they may want to add PrEP for some of the reason that you see listed here, to ease anxiety, to increase intimacy, and to ensure protection in case adherence is an issue for either partner. And lastly, in this PrEP research section of the manual, I wanted to point out that there have been 3 infections in people who were highly adherent to their PrEP over the last couple of years. The first two, as you see in this graphic, were exposed to highly resistant HIV strains, a rather rare situation, while the third was infected with a drug-sensitive strain. And that's a more problematic and confusing situation, at least for research, trying to tease out why a drug-sensitive strain had gotten through as far as being transmitted while being adherent to PrEP. This is to show that although PrEP is highly effective, it's not 100% preventive, as most other prevention methods are. They are not 100% preventive, excluding things like accidents and mutual masturbation. But these 2 pages that we have in the manual cover this topic in case you have clients who have heard about these cases and are wondering how that applies to them. So that wraps up the first section. But before we move on, I wanted to ask a question. And let me find. Okay. So the question being, and you all can vote on this, and the question is, true or false, the effectiveness of PrEP to reduce the risk of HIV infection is the same for everyone who takes it. And we'll give you a few moments to vote, so click true or false. So we'll give you the results here in a minute as soon as we end the poll. So, okay. So we've closed the poll for voting, and if we want to, does everybody see the results? So 87% said false, and 13% said true. So what's the answer? If we can go back to the slides. It's actually both, at least in my opinion. So it's true and false. So congratulations, everybody's correct in this situation. At Project Inform and Please PrEP Me, we often educate with phrasing like, PrEP is highly effective at preventing HIV, though not 100% preventive. So in that way, I think this statement is really correct. However, as I explained before, there's some variability with routes of exposure and dosing adherence. So those types of details that are found in the manual should be conveyed to appropriate clients, especially when you're talking about rectal versus vaginal or frontal exposures. I'll also cover lead-in doses in the next section, which is also different depending upon those routes of exposures. So those are the highlights for the first section, and let me move on to the second section in the manual, and that is the PrEP care section. And here are the topics in that section. Some are combined here to crunch onto the slide because I ran out of room there, and I'll give you a moment to review them. Your role as a PrEP navigator may have you involved in various steps along the PrEP care continuum, as you can see here in the graphic, depending upon your service program needs. So what are you involved with on a daily basis within your agency? It's not unlikely that navigators are actually the glue that helps PrEP users stay negative. So you're probably juggling lots of pieces along this continuum. Our page on this topic will hopefully stimulate ideas and help you define your role as a navigator. One of the central roles for navigation staff is screening clients on various facets of PrEP care. Who is eligible for PrEP? What health care do they have? What health care do they need? Checking in on adherence patterns and issues, and linkage to other support services outside the clinic. This section can help you craft questions that tailor to the needs of your clients, including what paperwork your agency wants you to fill out. A couple of the other pages describe various questions. Describe various questions and strategies to screen individuals for PrEP. So the CDC has listed in its guidelines 4 groups of people who would benefit from PrEP, and these 4 are sexually active men who have sex with men, sexually active heterosexual couples at significant risk, people who use drugs and inject drugs, and mixed status couples seeking conception. But beyond those groups, there are other ways to screen for actual HIV risk, notably around behaviors. So questions like, how often are condoms used? How, has your client had an STI recently, or has your client used PrEP recently? Then you also need to assess for insurance status and income and ability to adhere, et cetera, et cetera. So these pages cover those types of issues, as many as what they are, just so that you're crossing everything off the list as much as possible. So the next section I wanted to highlight was this topic page because, acute infection symptoms may occur at baseline or throughout the time that someone's on PrEP, and additional HIV testing may be indicated in these cases. Since there have been 3 infections while on PrEP since FDA approval, this is important for you and your clients to keep in mind, hopefully without getting too anxious over the symptoms of a legitimate cold or flu infection. Again, this page might work really well as a handout for your clients. One of the persistent topics that come up when I've spoken with local navigators is insurance codes. There are a few really good resources that explain these codes, and you can see them there from the guidelines to the AIDS Foundation, to NASTAD, and the CCC, the Clinicians Consultation Center. And insurance companies often require different codes for PrEP. So work with each plan to know which code or codes that they prefer. Also, prior authorizations are usually not anything to worry about at baseline, mostly because it's about making sure that Truvada that's being prescribed is for prevention and not for treatment. And sometimes also PAs are needed over time at quarterly visits. Denials also happen, but they're often resolved with using the right codes on insurance paperwork. However, sometimes additional challenges are needed, so you might need to be persistent over continued denials from an insurance company. It's really wise to nurture good relationships with a friendly staff person at those companies so you can complete the paperwork properly. And just to note, Project Inform advocates nationally and in California, so if you have a persistent issue with certain insurance plans or companies, please, I just implore you, please let me know about them. As an example, we and other advocates actually got United Healthcare this past summer to reverse its prior authorization policy. So your information and what you experience are important to us, and we can advocate, in California or nationally. The next topic page outlines the reasons why a person would start and stop PrEP. It's really patient-initiated, likely along this idea of seasons of risk. So those times when the person knows that they're at higher risk for HIV. Some people stop and never use PrEP again, while others start and stop again and again over time, and you can see that reflected in the graphics on the slide. But separate from actual risk, other factors can influence starting and stopping as well, such as current kidney health, ongoing access or lack of access to health care, housing and transportation issues, adherence issues, or even an HIV diagnosis. So there's a lot of things to consider around this, and the manual describes a lot more than what I can cover here again. Lead-in doses are needed as well, and they differ depending upon the route of exposure, like I said earlier, with 7 daily doses needed for rectal or back exposures and 20 days for vaginal or frontal or parenteral or needle sharing exposures. Another thing to consider when stopping, what's your client's exit plan from PrEP? What other prevention strategies do they have in place once they stop it? So as you can see, there are a lot of details to this, and these pages can help explain them further. I wanted to highlight this topic in a lot of ways as a reminder that it's not only gay men who can benefit from using PrEP. Mixed status couples who are trying to conceive can also utilize PrEP. It's often the case that mixed status couples who are in regular health care with a supportive and knowledgeable clinician can prevent the transmission of HIV to both the partner and the newborn. So we have a page on this in the manual, and again, this would be a really good piece to hand out to potential clients. And lastly, wanted to talk about PEP. About 4% of consumers to Please Prep Me's chat service here in California are actually seeking PEP. So what you may also find that as you talk with your PrEP clients, a certain number of them may actually need PEP. And as you may know, PEP is starting HIV meds within 72 hours of a potential exposure and taking them over the next 28 to 30 days. We have a 2-page info sheet on this in the manual, but just to warn, because this is something that comes up on Please Prep Me, a person would not PEP and PrEP at the same time. It's one or the other, except perhaps in very extenuating circumstances. But so far, I have never heard of somebody being on PEP and PrEP at the same time. So those are some of the topic areas in the second section, so hopefully you'll find some value in what I've covered so far. And I wanted to go on to the next pop-up question, which is also true or false. So that is, hold on for a second. Like people who live with HIV and are taking meds, those who want to go on PrEP will take Truvada for the rest of their lives. So if you want to, please click true or false. Give you a couple more seconds. Okay, we've closed the poll, and about 93% say false, and 7% say true. So we go back to the slides. The answer is false. In my experience, some people who have contacted Please Prep Me believe they actually have to stay it on indefinitely, but as I stated before, this really isn't the case. It's really about seasons of risk for each individual and meeting their needs based on their current level of HIV risk, and as their sexual health needs change over time. It's not going to be static from year to year. So let's move on to the third section of the manual, the largest one actually, and here are the topics covered in that section. It's the largest because of the somewhat complex nature of health insurance and knowing the ins and outs of various patient assistance programs. The details may feel overwhelming when you get into this, and I've definitely felt overwhelmed myself ever since FDA approval back in 2012. But I hope we've written the manual in a way that it empowers you and other navigators to keep up with paperwork. Also in the manual, we covered navigator responsibilities over about 3 pages. We thought it was important to describe the qualities of good navigation beyond those daily tasks that you may have. So how you interact with clients can go a long way to earn their trust, and here are details that helps you help them. So things like cultural humility and knowing local resources to send clients to if they're needed are covered in these pages. We also have many pages on finding the right insurance for clients and finding a supportive clinician as well. You'll likely need to get up to speed with how Cover California or any of your state marketplaces work, and I would suggest familiarizing with those websites, but as well as knowing the differences between Medicare and Medicaid and how to assess which plans are best according to the income and other needs of your clients. These pages also talk about helping uninsured people, and you can find you can find a flow chart at that URL at the bottom of the slide from Project Inform. So that just helps you work through insured and uninsured individuals. What's equally important is paying for PrEP and how clients are going to cover those costs. It's not all that common that commercial plans fully cover PrEP care costs, so people often have to utilize third-party assistance programs like those of Gilead, the Patient Assistance Network, or PAN, and the Patient Advocate Foundation, or PAF. As navigators, you'll likely need to get very familiar very quickly with these programs and try to work out best practices for your clients. And this is very top-line information on this slide. There's a lot of dense information on the pages in the manual. It's really important to know all of those details, so hopefully those pages are helpful to you and your clients. The next topic page is one that we'll soon add to the manual. It's not there yet. This is the one on the upcoming California PrEP Assistance Program, which is slated to launch in spring of 2018. It's the third resource to go to after coverage that's provided by insurance and those third-party PAPs that I spoke about in the last slide. The PrEP app will roll out in two phases, first for the underinsured and then for insured individuals afterwards. Now, other states have had similar programs such as New York and Washington and Colorado and others. So California's a little behind the curve, but hopefully this will be up and running next year. It will also use the same enrollment system as ADAP. So if you're already familiar with that system, then you have a leg up on this before next year. And just an FYI, another one, state advocates, including Project Inform, are regularly meeting with the State Office of AIDS to inform them on the program details of the California PrEP app. So any input from the Californians on this webinar would be great to hear, so we can forward that to the SOA. And lastly, wanted to point out these couple of online PrEP services, one called Murex and the other one called PlushCare. We'll be updating the Murex page soon to include the information on PlushCare, but they both essentially do online what PrEP navigators do in person, using a patient's insurance to walk them through getting PrEP, while their online clinicians prescribe PrEP within the states that the patients are calling. And you can see some of the reasons why this might be an appropriate avenue, option for your clients. Sometimes PCPs are not willing or able to provide PrEP, or maybe they're too, your clients are not willing to talk to their PCPs about PrEP, and so Murex and PlushCare offers an anonymous way to get PrEP along with the support services from those companies. So that wraps up the third section that I wanted to highlight, and I wanted to do one more question. And so let's move on to that one. And that is also true and false. Despite its cost, people at lower income levels without insurance can find ways to get onto PrEP. We'll give you a few moments to answer that, so please answer true or false. So the poll is closed, and we have 96% saying it's true, and 4% saying false. And the answer is true. And I'll couch that by saying, as the current healthcare crisis at the federal level heats up, how healthcare around PrEP changes over the next year is really unknown. A lot of advocates are a bit anxious about what's happening, and so we don't know the impact of the true impact of healthcare coverage on PrEP. But currently, what I can say is that many low-income people without insurance can access PrEP by getting onto Medi-Cal here in California, especially, and also those states that expanded Medicaid coverage over the last few years of Obama's administration, or by using Gilead's program, or even applying to the California PrEP app next year. So it is very possible for low-income people without insurance to get PrEP. And one last slide I wanted to show you. These are the sections that we are planning on adding soon to the manual, so more information to come. You can go to that URL on the slide, sign up to get notices when updates occur. And as you read the manual, please let me know of any incorrect or misleading information you find. and any topic areas that you'd like to see us cover in future versions. And I see there's a question to me. It says in an earlier slide there was something that started with an L instead of PrEP that I am not familiar with. Please explain. So I'm not sure what the L is referring to. So if you could, whoever typed that question, if you could retype it and explain a little bit further, then I can help answer that towards the end of the presentation. So I hope you found this presentation informative, but trust me, there's a lot more information in the manual, and thank you very much for listening.
And now we're going to hear from Roz.
Thank you, Linda. I am Roz Plotzker. I'm the STD Fellow here with CAPTC, as well as with the California Department of Public Health Sexually Transmitted Disease Branch. And just to cap things off, I wanted to go over what's new in PrEP. This past summer, the International AIDS Conference was held in Paris, and there were several interesting developing PrEP technologies that were presented. So this presentation will go over three main technology categories. The first is long-acting PrEP, which might be the L that the question for Alan was referring to, possibly. Also, there has been some research on topical vaginal PrEP. And finally, I'll talk a little bit about remote PrEP monitoring, which Alan mentioned is it's incredibly important to take into consideration adherence to PrEP on the PrEP care continuum. And so remote PrEP monitoring could be very useful in that. So to get started, for long-acting PrEP, there are two main strategies. The first is an injectable or shot form. Right now, the two main candidates are cabotegravir and rilpivirine. And there is also some research on implantable rods, both for cabotegravir as well as TAF, or tenofovir alafenamide fumarate. So to start with the injectable form, this slide is not nearly as complicated as it looks. Basically, there is a phase 2 trial that is being conducted by the HIV Prevention Trial Network, HPTN. This study is 077, and it is looking at the safety, tolerability, and also pharmacokinetics of cabotegravir. And essentially, there are two arms of this study. One is looking at an 800 milligram dose every 3 months, and the other is a 600 milligram dose every 2 months or so. And right now, the lower dose, let's see, there we go. The lower dose of 600 milligrams every 2 months or 8 weeks is the more promising of the two. And so the HIV Prevention Trial Network has started 2 phase 3 trials, which are essentially larger trials than phase 2, looking at cabotegravir at this lower 600 milligram dose. The study design is similar to the phase 2 trial, but with a larger sample size and for a longer period. So there are 2 arms of this research. One is for MSM and transgender women, that's HPTN 083, and that hopes to enroll 4,500 participants. And the second is HPTN 084, and that hopes to enroll a little over 3,200 participants. And the enrollment period for these is 2 years, and then those participants will be followed for about 4.5 years. In terms of rilpivirine, there's a phase 1 study, so an earlier in the research phase study that is being conducted by MWRI, and that is the MIDGE Women's Research Institute. This study is looking at specifically the pharmacokinetics and pharmacodynamics of rilpivirine in a much smaller sample. This study is considering 3 arms for females and males. The first arm is looking at a 1,200 milligram dose. The second arm is looking at a 600 milligram dose. And then the third arm is looking at the 1,200 milligram dose every 2 months, excuse me. So that study is ongoing, and currently, with regard to safety, all 3 injections are safe and acceptable. The injection site pain was the most common adverse event, and that's common for any injection drug. And in terms of accumulation, rilpivirine accumulation was found to be modest but significant. And so this is also a promising candidate and maybe moving on to a phase 2 trial in the future. So with regard to implantable PrEP, there are 2 types of implants, and I'm going to be focusing on the actual rod of the implant rather than the drug itself. This is about where the research is. And this information was presented by a researcher, Thomas Hope, who works with a project called Sustained Long-Acting PrEP, or SLAP HIV. So the first version is a biodegradable version, which means that the rod itself degrades in the body. And as it degrades, the drug is released, and the drug also diffuses into the body throughout the period that the implant is in the tissue. So this biodegradable version can hold up to 100 milligrams of the drug. There is a removable version, which is made by a type of a polyurethane material. And the way that the drug is released in this one is that it is diffused through the wall of the actual tube. And the tube wall characteristics are what control the rate of the drug release. And this one can hold up to 175 milligrams per implant. SLAP HIV is aiming for an implant that can last for 6 months. And so having a higher drug load may be helpful in having a longer time period for this rod to work. Right now, the removable implant is the more promising of the 2, and this research is actually focusing on some old school science dating back to the 1800s, where they're using the actual geometry of the tube to fine-tune the drug release. So, in other words, the diameter of the tube, the length of the tube, and the thickness of the wall are what they're using to figure out the best rate of drug release. And you can see in the photo just how small this little tube is. So, moving on to topical vaginal PrEP, there was a presentation about one candidate drug, dapivirine, and how the presence of vaginal flora might impact dapivirine's concentration in the vaginal canal as well as in the serum. So the objective of this study was to evaluate whether the vaginal microbiota, which is associated with BV, or bacterial vaginosis, which is a very, very common condition for women, might impact the drug concentrations in the genital tract tissues, as well as the plasma-vaginal application. And this is very important when considering real-world settings of the use of vaginal gel. So basically, they had 66 healthy, non-pregnant women who were HIV negative, also negative for gonorrhea, chlamydia, and trichomonas. On day 1, the women received the dapivirine gel or a tenofovir gel, and specimens were collected. And then the participants used that at home for a week. When they came back in, more specimens were collected, and the gel was again applied in clinic, and they waited 2 hours and finally collected their last specimens. And what they found was that genital and plasma concentrations of dapivirine were not decreased by bacterial associated with BV, and that dapivirine following vaginal application was unlikely to be impacted by the microbiota, which was associated with bacterial vaginosis. So this is very promising, and we can keep an eye out to see if dapivirine becomes a stronger candidate for this type of an approach. And finally, while we are waiting for the long-acting PrEP, we need to be mindful of medication adherence with the current PrEP regimens. And there are three main strategies for remote PrEP monitoring for patients who are now on daily PrEP. And one is electronic pill cases, also cell phone-based monitoring, and finally, ingestion event monitors. Electronic adherence monitors are essentially pill cases, and they monitor how many times the patient simply opens and takes a pill. And so this is the oldest remote monitoring technique and probably the simplest. There are also cell phone-based monitoring strategies, and these are dependent on patient use. So the first is a toll-free phone number attached to a pill or a blister pack. In other words, every time someone would take their pill, they can call or possibly text to the phone number listed to let the provider know that they took their medication. There's also wirelessly observed therapy, which is essentially direct observed therapy via video chat. And finally, this is the farthest on the horizon, but in my opinion, one of the most interesting, is an ingestion event monitor. This slide is actually using the example of tuberculosis medication, but it's also being investigated for PrEP. In this scenario, each pill is enabled with an ingestible sensor, and the patient wears a patch on their body. When the patient takes the pill, the patch can detect the ingestion, and then sends a signal to the patient's cell phone, which then sends the information via a server to a web-based interface, which the caseworker or provider can look up. So this may be the future of adherence monitoring as we know it. So the PrEP horizon, as we can see it today, involves potential long-acting PrEP, either as an injectable or implantable form, topical vaginal PrEP, dapivirine being one of the candidates, as well as remote PrEP monitoring for patients who choose to use oral PrEP on a daily basis. These are the abstracts that I discussed today, and you can find them on the International AIDS Society website. Thank you very much.
Okay. Thank you, Alan and Roz. It looks like there are just a few questions coming in, and I would like to remind people, if you do have any questions, please use the chat box. So, Alan, I don't know if you had figured out the question for the first something that started with an L?
Yeah. If it's about lead-in doses, and hopefully that's what this question is about, but if it's not, please type your question again. So lead-in doses are needed depending upon the route of exposure that the patient is most concerned with or will be encountering more. In the USPHS CDC guidelines, it does differentiate between rectal and vaginal exposure. So for rectal exposures, it's 7 daily doses before adequate protective levels of the drugs are saturated in rectal tissue. And then for vaginal or frontal exposures, it's 20 lead-in daily doses, as well as for syringe sharing behavior exposures. That's also 20 days lead-in doses. So it takes longer for those drugs to permeate vaginal tissue and to permeate all of the cells, the immune cells that are floating around the bloodstream as well. So that's part of the reason, the main difference between rectal, which is 7 daily doses, and vaginal and parenteral, which is 20 daily doses.
Okay, great. And Jay has asked a question, will copies of the presentation be forwarded? The answer to that for everyone is yes, it will. We will send a link to the recorded webinar as well as slides of the presentation. Mona has a question. Why would it be important for outside monitoring for prevention methods? She understands the importance of treatment, but why prevention?
That is an excellent question. Well, some of it relates to the lead-in, which Alan discussed, where, you know, these monitoring methods are especially helpful for people who have a very hard time getting to clinic or getting into care in, for example, under-resourced countries or rural areas. And so in these countries, a higher proportion of heterosexual women would be using PrEP, and they need that 20-day lead-in. So it would be helpful for the clinician to see that this woman has had her 20-day lead-in. Also, a lot of patients will communicate with their providers via cell phone, and so for a provider to, especially in these resource-limited settings, for a provider to be able to text with their patient and simply look up on the computer, oh, they have taken their pill every single day, or, oh, they've only taken their pill 3 times in the last week, something like that, would enable better counseling. And also, the adherence technology sometimes is combined with reminders. So if there is somebody who should be taking a pill every day and the sensor picks up that they haven't taken their pill that day, it might trigger a message just to remind the patient. So there are a lot of different ways that this can be used.
And if I could piggyback off of what was just said, is that we saw in clinical studies that those people who perceived themselves at higher risk were more likely to adhere to their medication. And so those folks who didn't think that they were at risk, even though in real life they perhaps were, maybe slacked off, missed doses or didn't think that taking doses was necessary. So these strategies to remind people to take daily doses, especially when it comes to vaginal exposures, are important to keep up with, with reminding folks to do that.
Thank you. Alan, this one looks like it's for you, and Greg is asking that Project Inform seems to, we can call and get a lot of information, but what kind of support can we get from Project Inform, and what other sources of support are there that we can access?
Well, Project Inform, we have many printed materials that are, actually once we're providing them for free. We lost our PrEP funding this year, so we're having to charge a nominal fee per piece, but it's very, very small, and most people are coming along with it. So there's several different pieces of PrEP materials. One, a series of PrEP booklets, one for MSM, one for transgender women, and one for cisgender women, both in English and in Spanish. We have a point-of-care card that talks about PrEP and PEP, and it's really great for street outreach or safer sex kits, and ERs also have been using them quite a bit. We have the PrEP flow chart that is a 2-sided piece that you can print out yourself that really talks, walks people through, not only you, but your clients, on how to get PrEP and how to pay for it. And the last piece then is the PrEP navigation manual, which anybody can download and print out as they need to. So those are, and then we also have videos that anyone can download onto their website and have their clients' community read. We're also collaborators with pleaseprepme.org, which is a California online chat service. So for those folks in California, if you haven't heard about Please Prep Me, we have a daily navigator on Monday through Friday that can help steer people to PrEP providers and answer questions around PrEP. So those are some of the things that we do. Again, like I said, we also advocate at the state and national levels, and those issues that you find that you might need more support and help with, please let us know, and I can forward that to the appropriate staff.
Thank you. It sounds like there are a lot of resources and support available. Appreciate that. Patrick has a question. Are there any plans to include PEP as a navigation feature?
For if it's in reference to Please Prep Me, we actually are already doing that. So not only actively as people are chatting with our navigators, but also as part of our search function on the website. So anybody that's going and looking for a provider, at least in California, they can screen or filter for PEP providers. So we are asking questions of our database providers whether or not they provide PEP as well. So yes, we already include PEP as a navigation feature. And if that's the question, then hopefully I've answered it properly.
Great. So it doesn't look like we have any more questions coming in. So if that's the case, then we'll be concluding. But I want to thank both Alan and Roz for this really informative webinar. And, you know, it seems like there's a lot of new stuff on the horizon from what Roz was telling us. Like, it clearly some interesting things that are coming up. And it sounds from Project Inform's end that, you know, the navigation manual has a lot of important information for us as providers that we will want to share and relay to our clients. We'll want to get familiar with on our own to be able to support our clients in, you know, helping people access PrEP. So thank you all for joining us today. We appreciate your attendance. And again, thanks to Alan and Roz.
Thank you.